sure we finish up on time. So good morning, everyone. Welcome to our second CPC case for the year. This is a 46-year-old gentleman with chest pain and shortness of breath that we're discussing today. So our patient's chief complaint is chest pain and shortness of breath that's been going on for approximately 1 year. And in our history of present illness, this is a 46-year-old African-American male who presents with chest pain and discomfort, or chest discomfort and shortness of breath that's been slowly progressive over the course of approximately 1 year. He reports left-sided chest pain located in the mid-axillary line around the level of the 8th to 10th ribs. The pain is sharp, an 8 out of 10 severity, and he states that it occurs mainly at night when he's laying down. The pain is worse with certain movements, but not related at all to exertion. And this pain's been occurring daily now for the past 5 to 6 weeks. The only other associated symptom the patient complains of, in addition to the discomfort and shortness of breath, is an intermittent, non-productive cough, but he denies any hemoptysis. As far as his past medical history, the patient has coronary artery disease. He's had 2 ST elevation myocardial infarctions, the first in December of 2008, the second in April of 2009. Both were felt to be related to cocaine abuse. He has hypertension, peptic ulcer disease, and depression. His only surgical history is an emergent surgical repair of a perforated duodenal ulcer in 2007. He has no known drug allergies. His current medications are budesonide formoterol and HILAR, 2 puffs twice a day, tiotropium bromide daily, aspirin, lisinopril, metoprolol, pravastatin, citalopram, and PRN trazodone. Social history: the patient is currently single and unemployed. He was fired from his job at a nut and trail mix packing company in Roberson, North Carolina in early 2009. He quit smoking approximately 2 months ago and drinks a 12-pack of beer weekly. He also admits to continued cocaine use, both sniffing and smoking routes, for approximately 6 years, 2 times a week. He was also incarcerated for a period of about 6 months 5 years ago. His family history is positive for coronary artery disease in his mother. His father also had a stroke, and he has a brother with type 2 diabetes. He has 2 daughters that are in college currently and are both healthy. Under review of systems, he denies any fevers, night sweats, or weight loss. He does complain of fatigue and falling asleep very easily and very frequently. He snores loudly at night and has frequent awakenings. Under physical exam, the patient's blood pressure is 134/87. His pulse is 58. Respiratory rate is 18 breaths per minute. He's 5 foot 11 inches tall and weighs 223 pounds. In general, he is well developed and well nourished, but in some mild respiratory distress. His head is normocephalic and atraumatic. The pupils are equoround reactive to light. The conjunctiva are normal and pink. There's a clear oropharynx with moist mucosa, no lesions, and the fundoscopic exam is normal. The patient's neck is supple, and there's no tracheal deviation or palpable cervical lymphadenopathy. There's no thyromegaly or JVD. He does, on respiratory exam, he does have diminished breath sounds in the right lower lung with end-expiratory wheezing, but there are no audible crackles or rhonchi. His cardiovascular exam, his heart has a regular rate and rhythm. S1 and S2 are present, and there are no murmurs or gallops appreciated. The abdomen is soft and non-tender with no organomegaly appreciated. And there is a well-healed midline surgical scar noted. Active bowel sounds were present, and the stool was guaiac negative. There's no CVA tenderness. And on the musculoskeletal exam, he had full gross range of motion, with no clubbing, no edema, no cyanosis, no tenderness in the extremities. There's no synovitis or joint effusions noted. Neurologically, the patient's alert and fully oriented. Cranial nerves 2 through 12 are grossly intact, and there are no focal sensory or motor deficits appreciated. And the skin is warm and dry without any rashes noted. His laboratory studies revealed a white blood cell count of 6.5, with hemoglobin of 17.3 and hematocrit of 50.6. The MCV was 94. Platelets were 240,000. His metabolic panel showed a sodium of 144, potassium of 4.1, excuse me, chloride of 109, bicarb of 24, BUN of 11, creatinine 1.4, and calcium 9.1. The PT was 10.1 and PTT was 25.8. Chest X-ray was notable for bilateral HILAR and lymphadenopathy. A chest CT with contrast was performed, and it showed marked mediastinal, paratracheal, and prevascular right axillary and bilateral HILAR lymphadenopathy with partial calcification identified. There were no fractures, lytic or blastic osseous lesions seen, and calcification within the left anterior descending coronary artery was also identified. The patient then underwent bronchoscopy, and it revealed gross distortion of the left paratracheal region as well as extrinsic compression of the left main stem bronchus. No intraluminal lesions were noted within the bronchi, but endobronchial ultrasound was performed, and there were multiple enlarged lymph nodes, and multiple attempts were made at lymph node biopsy, and a further diagnostic procedure was performed.
I loaded up a couple of the older studies because I wasn't totally sure yesterday if we were going to get the newest studies. So since they're on here, I'll just show them. This is an X-ray from December 11th, 08, a portable film, and it's a little bit limited by its portable nature, a little bit low volume, but it does show some prominence of the HILAR region sort of bilaterally, a little bit better appreciated on the right than the left. And there's also fullness of this right paratracheal region. Here's the tracheal air column, and then there's too much soft tissue density kind of right along the border there on the right side. The history for that study was chest pain, and it was read as some mild prominence of the right paratracheal soft tissues and right hilum. It was felt that could be vascular, but a follow-up PA and lateral standard X-ray or CT suggested to exclude adenopathy. And a CTA was ordered at that time because of chest pain. They're worried about dissection, and this is a CT performed the same day, and at that time we were doing these as a non-contrast and then followed by a contrast CT. The non-contrast is to look for intramural hematoma in the aorta, but we don't see that. Here's the contrast portion, so we see the bright contrast in the arch vessels here. Here's the trachea, and then there's a soft tissue density here in a right paratracheal location. This is an enlarged lymph node. As we go a little bit lower, again you have trachea, here's the aortic arch, and then you see 1, 2, 3 lymph nodes lined up here in the prevascular space. And this density here it's not a vessel, this is actually a calcification. And then this is a lymph node here, and then that's another lymph node here, kind of surrounding the trachea on the left and right. This is a little bit lower down. Here's the pulmonary artery, and this is to demonstrate the HILAR regions. So on the left, you see the artery here outlined in contrast, and then these soft tissue areas are the lymph nodes. It's part of a lymph node here, subcarinal. This is the just below the carina here, left and right mainstem bronchi, and then adenopathy in the right hilum as well. And then one slice lower, or a few slices lower, again a bulky node here, and then bilateral HILAR lymph nodes. You can see this is sort of a symmetric pattern with some central small but coarse calcifications. This is just another way of looking at it in the coronal plane. Here's a trachea, and then you see all this soft tissue density here, left and right. It's all adenopathy. And this is going back a little bit farther towards the spine. Soft tissue density here. This is all sort of a confluent nodal mass here, and then kind of node, some nodal tissue here on the left as well. These are axial images performed with a lung window setting, and here's just below the carina here, the bronchi. You see a little bit of ground glass attenuation posteriorly. That's probably due to volume loss. If you flip the patient over, scan them on their stomach, you'd probably see the same thing in the opposite location. But there's really nothing pathologic within the lungs. There's no fibrosis, no nodules, no pleural effusion, no airspace disease that's unexpected for the positioning. So a little bit of dependent atelectasis, but otherwise looking pretty good. And a little bit lower down here, we're at the base of the heart. And the other thing that was commented on this study was there was some hypo-attenuation here in the ventricular apex. This is the septum, the left ventricle. You can see the enhancement here of the left ventricular wall, the septum. And then there's an area of decreased enhancement here at the apex. So this was felt to potentially represent an age-indeterminate infarct. This is a right axillary lymph node that was mentioned earlier, and so there is a prominent right axillary node also. So this CT scan showed bulky mediastinal and bilateral HILAR lymphadenopathy with lymph node calcifications. It was felt this probably represented sarcoidosis, and they described coronary artery disease with this area of low attenuation that we just looked at. Here's a differential diagnosis for calcified lymph nodes. Sarcoid, symmetric bilateral HILAR, as well as mediastinal would be the most likely based on the imaging appearance. Old granulomatous disease is the most common overall that we see, and then you have a bunch of other things that are less common. Could this be a neoplastic process? Lymphoma usually doesn't calcify unless it's treated, and obviously some metastatic adenopathy can calcify. Mucinous adenocarcinomas, thyroid, if there was a history of osteogenic sarcoma, but the way those lymph nodes look would make that unusual also. And here's the follow-up study. This is from September 2010. This is the most recent CT that we had. And here's this right axillary node again. Prevascular nodes, looking pretty similar to the old study. You can again appreciate these calcifications, kind of central course calcifications. There is a little bit of displacement of the trachea here to the right by these nodes, which is similar to the old study. So it is a little bit pushed over. There's some mass effect here. And kind of similar HILAR lymph nodes. Kind of subcarinal and bilateral HILAR. There's a little bit of scoliosis here. You can see the spine going this way, but then the trachea is a little bit pushed to the right, and then you have these lymph nodes that we've already discussed. The lung windows from this more recent study, again, show no pulmonary disease. The lungs show no nodules, fibrosis, or anything like that. And this is the most recent imaging study we had. This is from February 26 of 2011. And the lungs are okay. But again, you see this bilateral HILAR fullness and the trachea a little bit to the right, and then you have real prominent right paratracheal stripe. That's it.
Thank you, Dr. Thaxton. And now. So our house staff, the differential they came up with was far and away sarcoidosis was the most common diagnosis. Tuberculosis came in a close second. They also felt that cocaine-induced lung injury, and several people mentioned crack lung, which I don't know would explain the adenopathy, but cocaine-induced lung injury was one that was a common diagnosis. And then lymphomas and various lung cancers came in as well. Looking at the third-year medical students, tuberculosis seemed to beat out sarcoid, but they both appeared, as well as lung cancer. So those were the main diagnoses from our students and house staff. So without further ado, I will turn the discussion over to Dr. Discuss this case further. We have the esteemed Dr. Shaw from the Department of Pulmonary and Critical Care Medicine. We'll go through this with us.
Thank you. I appreciate the offer to participate with this from Todd and Zubin. anytime I do something where I learn, it's a good day. And so I've certainly learned a lot from this, and hopefully 20 minutes from now I won't be too humiliated. All people in internal medicine, part of our job is doing a differential diagnosis and coming to a likely diagnosis. And I do a lot of work with the second-year medical students on clinical reasoning. So I thought I'd just spend a couple minutes talking about approach to differential diagnosis, which is really what this exercise is. There's two main methods that we use. One is kind of an intuitive approach based on our previous experience. It's not terribly scientific. You know, we've seen XYZ patterns before, and we think that that leads to a diagnosis of D. You can be a little bit, you can make mistakes if you totally rely on pattern recognition, because you get into a rut and you stop thinking outside the box. But certainly somebody like me who have been doing clinical medicine over 25 years, this is a big part of how I formulate a differential diagnosis. And then of course there's more reasoned, evidence-based methodology where we look at probabilities and eliminate things that are less probable. It's more rational. And hopefully today I'm going to combine both of these methods in a differential diagnosis. I went to a really interesting pathology grand rounds Monday, and I think 10 years from now a third method will be maybe most important, and that is use of genomics. Mark Mazur about a year ago did a grand rounds on critical care medicine, in which he brought up the fact that in the near future, when somebody comes into the ICU with septic shock, we'll get a PCR analysis and within hours know that it's pneumococcal sepsis. We'll do a proteomic evaluation and see different cytokines, and based on those cytokines we'll tailor our treatment, and it'll also help us with other diagnoses. So I think we're on the edge of moving toward genomics in our differential diagnosis, but I'm not going to use that today, and kind of center more on the first two. So an intuitive approach, when I first read this case, I thought about a patient that I'll always remember that I saw over 20 years ago when I first came here. This was a 20-year-old woman who had shortness of breath. We did a VQ scan. This was really a little bit before CT angiography was done to rule out pulmonary emboli. She had absent flow to the right pulmonary artery. Her chest x-ray showed a little HILAR mediastinal adenopathy similar to this patient. A CT scan showed kind of a fibrotic lymphadenopathy in her mediastinum similar to this patient. We ultimately had mediastinoscopy done, and it wasn't sarcoidosis. She had mediastinal fibrosis, probably due to previous histoplasmosis exposure. So when I read this case, I immediately recalled this patient and put this kind of high on my list. So that was kind of based on my intuition and previous experience. But obviously it's a mistake in an academic situation to totally rely on your experience. So evidence-based approach, when I look at patients and data, I like to try to sort out what's important and what's less important. And this is probably an area where many of us make mistakes. We say something is important when it really isn't, or vice versa. But the factors that I thought were important in this case, he's 48 years old, and as Todd mentioned, he's had chest pain and dyspnea for a year. I thought it was very important that he had no weight loss or fever. His basic laboratory tests were normal. So immediately that jumps out at me. This is probably not some active infection or active malignancy. There are certain more indolent processes that it could be, but I didn't think that was very likely. We had a CT scan from '08 and another one from 2010. Not a lot of difference. Both of them show extensive HILAR mediastinal adenopathy with calcified nodes, and I'm going to talk a lot about calcified nodes in a few minutes. They did a bronchoscopy in 2010 and did FNAs of these mediastinal nodes using EBUS. And as we saw a few weeks ago with Mark Bowling's presentation, EBUS is ultrasound guided FNA. So you have this ultrasound on the end of the bronchoscope, and it tells you you're looking at lymph nodes, and you stick the needle into the mediastinum, so you are really sure that you're getting into lymph nodes. And this patient had EBUS, FNA, and the report I had on my scenario was scant lymphoid tissue. Now, ordinarily, you'd think somebody with this bulky amount of lymph nodes, you ought to get a lot of lymphocytes, and it'd be a slam dunk that it's lymphoid tissue. But there were scant lymphocytes. So that made me think that maybe there's a lot of fibrosis in these lymph nodes. Also, this patient had marked compression of the left bronchus. It wasn't an endobronchial lesion like a lung cancer, so these nodes are obviously pretty aggressive and really compressing the left bronchus. I thought it was important that his chest pain was chronic for a year. It's worse when he lies down. So this obviously isn't coronary artery syndrome or dissecting aortic aneurysm or pulmonary emboli or ruptured esophagus, the kind of things that we always think about. Things that I thought in the scenario that were less important and are probably distractors. He had cocaine and alcohol abuse. You know, cocaine can cause a lot of pulmonary problems, pulmonary hypertension. Maybe the lifestyle would predispose him to HIV, and maybe this case is going to turn out to be HIV with adenopathy related to that, or Kaposi sarcoma. But I kind of doubt it because of this clinical scenario. He's a smoker. Could this be lung cancer? Not very likely. This is bilateral lymphadenopathy, usually with lung cancer or lymphomas. It's more unilateral or asymmetrical. Also, I think if this were lung cancer, we'd have some changes going on in this 2-year period. So he does have symptoms of COPD. He's on medicines for COPD, but I don't think that's really important to this adenopathy that we're dealing with. He had a peptic ulcer and had surgery for that. He obviously has symptoms of obstructive sleep apnea, kind of one of my favorite diseases, but I don't think that's pertinent here. Ischemic cardiomyopathy. Maybe this is just going to be sarcoidosis with sarcoid cardiomyopathy, but in the scenario I had, he had had cardiac catheterization, he had extensive coronary artery disease. So I think he probably does have ischemic cardiomyopathy related to his cocaine and smoking, and that it's probably not a sarcoid cardiomyopathy. So the differential diagnosis of things causing mediastinal lymphadenopathy I've listed here. Obviously, sarcoidosis has to be high on our list. A variety of infections, especially old granulomatous disease, histoplasmosis in the Midwest and Southeast is pretty common. Again, I wouldn't think that it would be an active tuberculosis or active infection because of the chronicity of his condition and normal lab tests and no fever. Could be any of these malignancies. I was talking briefly with John Fogarty about this yesterday, and of course you always get second thoughts, and have I blown it? And John said, oh, maybe it's Castleman syndrome. Castleman syndrome is an unusual lymphadenopathy with B-cell lymphocytes. There's a lot of cytokines produced. Those people are usually very symptomatic. They have weight loss, fever. So I really kind of dished that. And it could be, you know, it could be some indolent sarcoma. Sarcomas usually are more out in the lungs and the pleural space and not just mediastinal adenopathy. So I'm really going to focus on, is it sarcoidosis, or is it this condition fibrosing mediastinitis, or maybe a combination of the two? Mediastinal tumors, and just kind of as a resident medical student teaching point, you know, we all should remember there's anterior, middle, and posterior mediastinum. The tumors in the anterior mediastinum I've listed here: germ cell tumors, thymoma, lymphoma, thyroid. Middle mediastinum, lung cancer, cysts, Hodgkin's disease, and posterior mediastinum, neurogenic. But this is kind of bulky mediastinal adenopathy. As we saw in the imaging, it was kind of throughout the mediastinum. It's not localized to one of these three areas. And I just put this slide up for kind of a review teaching point. This is just an image I copied of a thymoma in the anterior mediastinum. This is a nodular sclerosing Hodgkin's disease with adenopathy. So it's really getting, this CPC wants me to say, what diagnostic test would I do next, and ultimately what do I think it is. And the way we obtain specimens from the mediastinum, and again, I think this is a benign disease. I really have a choice of any of these three. Mediastinoscopy is kind of the historic gold standard, where a surgeon makes a small incision, general anesthesia. He can really sample right-sided nodes very well, some subcarinal nodes. If all you have is aortical pulmonary window nodes, this procedure really can't get to the AP window. They have to do a mini thoracotomy. Some people call it a Chamberlain procedure to get into nodes on the left side. So when you see nodes on the left side in the AP window, you can't do just a simple mediastinoscopy. Mark Bowling did a great job talking about transbronchial FNA. We put the bronchoscope down, we poke the needle into the subcarinal area and sample that area. And if we use ultrasound, you get a little higher yield. There's another way of sampling these mediastinal nodes that the radiologists do: CT-guided transthoracic needle biopsy. To my knowledge, we're not doing it here to any great extent, but it has some value, but probably has more complications than doing transbronchial FNA. This is the EBUS scope with a needle that you poke into the mediastinum. This is the ultrasound device. This scope costs over $100,000. We have one here in the hospital. It's expensive to repair. Now, the yield of sampling the mediastinum and getting a diagnosis with this is very high with lung cancer. So if you have lung cancer and mediastinal nodes, it's probably over 90% sensitive at diagnosing that. But what is the sensitivity in benign diseases, like if you think it's sarcoid? And I was a little surprised by this report that showed the number of FNAs, and when we do FNAs, usually we do about 5 of them, it's about 83% sensitive for diagnosing sarcoidosis. So it's not perfect, but it's pretty good, and it's a pretty safe test. It's much less expensive than mediastinoscopy. Earlier this week, Dave Green and I had a similar patient, and we did FNA and got granulomatous inflammation consistent with sarcoidosis. So this is a really good technique. Now, this patient had EBUS FNA, and it was non-diagnostic and scant lymphoid tissue. It still could be simple sarcoidosis, but you know, it's a test with 83% sensitivity. The CT-guided transthoracic FNA of the mediastinum, the radiologist basically goes in from outside the chest, puts a needle and gets into the mediastinal nodes. It has a similar yield if you suspect sarcoidosis to the transbronchial FNA. It's around in the mid-80s. It has a higher complication rate, about 20% pneumothorax. And these are some images showing how they can put a needle into these nodes and get specimens. But obviously here is a case where they did it and there's a pneumothorax. Most of the pneumothoraxes in this procedure are pretty small and easily managed. But that's another way of approaching the mediastinum. So let's return to the two diagnoses that I'm really centering on. The first one's sarcoidosis. We all know it's a multi-system disorder, non-caseating epithelioid granulomas. You must exclude especially infections that can cause that. It involves the chest, and by lung I mean lungs and mediastinum, 95%. Hypercalcemia is a little bit unusual. It's probably related to macrophages increasing vitamin D production, and so you get hyperabsorption of calcium. This patient had a cardiomyopathy, and certainly sarcoidosis affects the heart, but only about 5% of our clinical patients do we recognize sarcoidosis affecting the heart, but in autopsies, about 25% of autopsy patients have granulomatous inflammation in the heart. The most common things we look for on an EKG are conduction disturbances. But again, I think this patient's cardiomyopathy probably is ischemic related to his cocaine use. Does every patient who has bilateral HILAR lymphadenopathy need to have a biopsy of their nodes? And I see this a lot where a patient has had a chest x-ray for some reason and it shows bilateral symmetrical HILAR adenopathy, and they come into the pulmonary clinic and the fellows are hot to trot to make a biopsy of these nodes. But the answer is no, and the classic article addressing this is Winterbauer's article long time ago in 1973. He looked at 100 patients with bilateral, and this was pretty much symmetrical HILAR adenopathy. 47 of these patients were asymptomatic, they had normal blood tests, and they all had sarcoidosis. So if you biopsy these patients, you're going to find sarcoid, but you're not going to treat them. An asymptomatic sarcoid patient with bilateral HILAR adenopathy just warrants follow-up. So when I see patients like this, and again, they're asymptomatic, normal blood tests, I just follow them. I don't put them through a procedure. But the patient we're dealing with today has chest pain, he has shortness of breath, so he deserves a biopsy to find out what's going on. The pathogenesis of sarcoidosis is fascinating, and I asked Dr. Katari to come here today. From 1916 to the early 1970s, everybody thought sarcoidosis was a disease where immunity was decreased because these patients were allergic to common skin test allergens. You put a PPD on them, a Candida skin test, they're allergic. So everybody said, well, whatever this disease is, their immune system is deficient. But it was really in the 1970s, and Dr. Kataria, in my opinion, really changed the whole way of thinking about the pathogenesis of sarcoidosis when his studies showed that it's really a hyperimmune condition where lymphocytes are producing cytokines and tumor necrosis factor and interleukins, and this causes formation of granulomas. So Dr. Kataria really changed the whole way that people think about the pathogenesis of sarcoidosis. And this work is really continuing in our pulmonary division now. Laura Barber received an award at the American College of Chest Physicians earlier this year on her research that was done with Dr. Arce and Dr. Weezar, Mary Jane Thompson, and others. So I'm glad that Yash was here today, and I really think this is one of the most important findings of sarcoidosis in the last 100 years. I'm going to change from sarcoidosis now, and I may be crashed by this wave, but I want to talk more about fibrosing mediastinitis. A big medicine review of about 110 patients with this, published in 1988. The symptoms were similar to our patient: cough, dyspnea. Our patient did not have hemoptysis. He had sort of a pleuritic kind of a pain, some wheezing. Most of these patients presented age 20 to 40. The patient of mine that I showed from 1983, she was 20 years old. Our patient today is 48, so he's a little bit older than these patients. The thinking about fibrosing mediastinitis is that you have some underlying antigen, and probably old histoplasmosis is the most common. Other infections lead to a granulomatous mediastinitis, and in many people it just kind of resolves, but in other people, for reasons we don't understand, they really develop a fibrotic reaction in the mediastinal nodes. There's a lot of calcification. So these aren't typical lymph nodes loaded with lymphocytes. There's a lot of scar tissue and fibrosis. And these lymph nodes get bigger and bigger, and then they cause problems of SVC obstruction, esophageal involvement. The patient we have had tracheobronchial compression. His left bronchus was compressed from outside. The patient that I had in 1983 had compression of her pulmonary artery. There are other things that can lead to this. Sansert was a drug that used to be used to treat migraine headaches, and there was an association, silicosis, some malignancies, and these other things are much more unusual. Far and away, old histoplasmosis is the most common underlying cause of it. The natural history of fibrosing mediastinitis, you know, about a third of people ultimately die from this, from cor pulmonale or respiratory compromise. The patient I have is still alive. In fact, she's a little overweight and has sleep apnea now, but she walks around. She has decreased flow in her right pulmonary artery, but she's had a good life. Surgery has been done a lot in these patients. Trying to do a pneumonectomy is hazardous with a 50% mortality. And in the medicine review, basically the conclusion, and I wish we had like John Moran here, but trying to do reconstruction and resect this bulky adenopathy is hazardous, rarely beneficial, and people sometimes die from that. Antifungal therapy and steroids have been tried but really don't do anything. This is kind of old, burnt out granulomatous disease. Now, I want to center on whether this is just simple sarcoidosis, or is it fibrosing mediastinitis, or maybe it could be both. But this patient had calcified nodes. And Harold Israel at Jefferson in 1981, he and Dr. Kataria probably have the biggest experience with sarcoidosis patients in the United States. This was a series where he looked at calcification of sarcoid nodes. All these patients had had sarcoidosis for over 10 years. So these are kind of chronic sarcoid patients. Of the stage 1 sarcoid patients, and if our patient has sarcoidosis, he's stage 1 because his lungs are normal, this is only in the lymph nodes. 20% have, in his big series of, I think around 110 patients, had calcification in their nodes. So it certainly happens, not terribly common though. When I see calcification in nodes, I keep sarcoid in my differential diagnosis, but I tend to think more of other granulomatous infectious diseases. Now in fibrosing mediastinitis, and I'd like to give a lot of credit to the Lopus Library, which dug these old articles out for me and sent them to me. Nearly all the images show a lot of calcification in the nodes. They didn't give a percentage of patients who have calcified nodes, but it's virtually all of them. So just statistically, calcified nodes, you'd think much more of fibrosing mediastinitis than simple sarcoidosis. So I'm coming down to what I think this is, why I think this is more likely fibrosing mediastinitis, and maybe the patient has sarcoidosis and fibrosing mediastinitis, but I'm gonna favor fibrosing mediastinitis. The lymph node calcification is a key. This was another article that looked at lymph node calcification and sarcoidosis. These were patients who had sarcoidosis less than 10 years, and a very small number of them in fresh, newly diagnosed sarcoid patients had calcification. This patient had real extrinsic compression of his left bronchus by these nodes compressing it, and certainly we see a lot of sarcoidosis patients that when you put the bronchoscope down, there's some narrowing, but I haven't seen too many of them where that left bronchus is like totally blocked. That's kind of more aggressive than what sarcoid nodes do. But it certainly happens with fibrosing mediastinitis. And the last one is a real key to me. This patient had EBUS, FNA, and they said scant lymphoid tissue. That tells me that there's probably a lot of fibrotic material, calcification, not a lot of active lymphocytes, which favors more fibrosing mediastinitis. So they asked me what procedure would I do. I would have done mediastinoscopy on this patient. He had a lot of right paratracheal nodes. It would be very easy to get. Maybe they did a thoracotomy with biopsies, but I think it would be simpler to do mediastinoscopy to make a really good tissue diagnosis. I think it probably shows fibrosing mediastinitis. Most of these patients, the etiology is not proven, although we think it's old histoplasmosis. I'm going to think that the stains for infections were negative. Possibly he had sarcoid and granulomatous mediastinitis, and in the big series of fibrosing mediastinitis, like 4 out of 160 patients also had sarcoidosis. Would they treat this patient with steroids? I'm not sure what they've done with this patient, but if it's fibrosing mediastinitis, there's really no treatment. Bronchial stent. So you have a patient with a really blocked left bronchus. Do you put a stent in there? My colleagues who do stents say, we don't like putting stents in benign disease because you get a lot of granulation tissue. It's hard to remove the stents, and down the line it creates more problems than good. So I doubt if anybody would put a stent in this patient because I think it's benign disease. Now the other issue, I was with the fellows yesterday, and Heron Mehta said, you know, in that CT scan, there's an axillary lymph node. You know, wouldn't you go for this axillary lymph node? It's a lot easier than going into the chest. And earlier in the week, I had sort of dished him because we had a patient with an axillary lymph node. Now, this patient had a lot of symptoms, and before I got on service, they had done a biopsy of it, and I said, that's probably not going to show anything. Well, the patient had nodular sclerosing Hodgkin's disease, so he had a good laugh on that. If this turns out, out that the doctors managing this patient did an axillary node biopsy, and it's Hodgkin's disease. Heron, you're out to wherever you want to go in Greenville, and I will eat humble pie. So maybe they went for the axillary lymph node, but axillary lymph nodes most of the time are kind of a waste. So that's why I may be slammed on this. But anyhow, we'll see in a minute how wrong or right I am. Regardless of whether I go down hard, I'm going to enjoy basketball the next 3 weeks because I've got a good team.
Thank you for that excellent discussion, Dr. Shaw. I don't know why you would go and ruin such a wonderful discussion with a picture like that at the end of it, but
Okay, first of all, I should say, regardless of the diagnosis, I have a lot of respect and admiration for Dr. Shaw, because he's willing to do what few of the faculty in this audience are, and that is to get up and prepare for a CPC, which takes a lot of time and effort. As a matter of fact, Dr. Shaw has presented twice this year in Friday morning conferences, and I think he deserves a round of applause and a lot of admiration. So having damned myself with everybody in medicine, first of all, this biopsy was read by Greg Gagnon. And it was a mediastinal lymph node biopsy, and this is the low power. And the problem with low power whenever you're using computer imaging, that the image is not the best, but the important thing is there's very little lymphocytes here. There are these nodular lesions here. And if you go a little bit higher up, you'll see that these nodular lesions are composed of histiocytes. There's no caseation. There's a fair amount of fibrosis in here. And you go higher, non-caseating granuloma. You see sarcoid. Well, there's only one problem. You've got these two-ton or foreign body giant cells scattered through the biopsy. And you go higher, there they are there. And you've got these clear spaces in here. And these clear spaces contain something. You can see here and here, and you get an idea that there's something in there. And you can see it here and here and here. And these were refractal. And what we felt was that this was a granulomatous lymphadenopathy secondary to foreign material (talc). And was it perhaps due to the fact that if that's what it is, I think his cocaine use and his inhalation is a lot more important or a lot more severe than what he indicates it is. However, and the reason we're doing this is this, you go by, Occam's razor, one process. You could always say, well, this is sarcoidosis plus. But remember, sarcoidosis is a diagnosis of exclusion. Of course, the problem is you then see articles like this. Cutaneous sarcoid foreign body granulomas develop in sites of previous skin injury after systemic interferon alpha treatment for chronic hepatitis C, back in 1999. And there's lots of articles about this. And here just shows you a lesion here from an online journal. This looks exactly like what we have. And the problem I leave you with here is, once again, what are you calling sarcoid and everything else? And their argument is that foreign material of any type will induce a sarcoid type reaction. I still think it's the talc, or whatever the foreign material is, what's causing this. I don't think it's sarcoidosis, because once again, you have a reason for your lesions. Okay? It is very, very rare. As I spent a fair amount of time looking at this, the talc, the cocaine lung crack, I would have trouble because that would be more pulmonary injury than it would mediastinal. I think your sarcoidosis and your other differentials that were here were okay, but once again, The pathologist gets to see the package after the surgeon opens it. And I'll leave you with that. Thank you very much. Questions from the audience for any of all of us?
With that degree of fibrosis, would you still consider it a secondary mediastinal fibrosis, even if you have?
You could consider it a secondary mediastinal fibrosis. The cases I've seen, though, have a lot more fibrosis and less granulomas. As a matter of fact, I did an autopsy on an 8-year-old kid that had really severe mediastinal fibrosis. They actually had a stent in to keep his trachea open, and we never discovered the etiology of it, but it was all fibrosis. You could say, well, this is a granulomatous process on the way to a secondary fibrosing mediastinitis, if you wanted to do that, okay? Yes?
John, you talked about the distribution in regards to the top of cocaine. He had an occupational exposure history, worked in a trail mix factory, as I recall. Any comment about any possible origins there?
I don't think so. That
factory does peanuts, and certainly
Right.
peanut dust can cause asthma and reactive airway
Right, but-
things. I don't think
But these are actual particles, which I doubt you would get with a peanut thing, and it's all, the thing is, it's all mediastinal, okay?
You know, one of the things when I looked at the chest X-ray, it doesn't show lobulated, typical what we see, lymphadenopathy in sarcoidosis. And you could see it kind of flat. And so, I mean, it can happen in sarcoidosis, but usually when that happens, the lymph nodes shrink. Here is a big mass around the mediastinum. And I think that very much suggestive of mediastinitis. Again, you found sort of granuloma, but this is a sort of situation where there is a granuloma, but there's a much more fibrosis going on along with that, without resolution of the lymph nodes.
Well, I described what we see, and what I saw was a mixture of fibrosis and granule. I agree, you know, I agree about the X-ray image, but remember, X-ray is a dark shadow of what pathology is. Sorry, but
I think based on those images, I mean, those nodes are pretty well defined.
yeah.
The calcifications were small relative to the
Yeah.
size of the nodes. I mean, the cases I've seen of fibrosing mediastinitis, oftentimes the calcifications are chunky, a little bit bigger than that relative to the size of the node. A lot of times the nodes are more ill-defined because there's fibrosis sort of surrounding them, kind of matted together, you know, sort of compressing arteries and bronchi. The CT scan's not as impressive as I guess what they found when they looked down in the airway,
Yeah.
because it wasn't real obvious that there was a lot of compression of the airway on the CAT scan at least.
And the other thing, that I agree with you, the fibrosing mediastinitis that I've seen, you know, both in autopsy and in descriptions and cases, there's generally, everything's sort of fibrosed together, they're not, you know, and the fibrosis is overwhelming. But remember, at the autopsy, we're looking at the end stage process.
Could you tell from the size of the crystals?
The thing to have done was probably to send it out for X-ray diffraction. But the problem is, who would pay for that? PCMH certainly wouldn't pay for it. And as you know, the dean is telling us all that we must save money, we must save money. And our department has always run in the black, and unfortunately, we will continue to run in the black at the expense of academic truth. Okay?
Actually, you know, I presented this case in our case conference, and Dr. Shaw was not there. And when I reviewed the literature over the last 2 years, I think I started my research from 1985 or something.
Right.
There were only 2 reported cases in the literature, and this is number 3 for cocaine-induced mediastinal lymphadenopathy.
Right. I mean, I looked too, and I thought, well, and then what I did was I looked actually at talc granulomas in the lung, which are much more common. And histologically, they looked a lot like this. Now, talc, they describe as, you know, oh, well, you get Maltese crosses, but you don't always see that, and, you know, could have been something else. The only way really to have told was to have really done X-ray diffraction. And like I said, that's, if somebody wants to pay for it, I'm sure we will be happy to send it out. Thank you.
Thank you for excellent discussion.
Paul, before you go,